I'm going to walk you guys through a trauma patient's journey from the time they hit the door to the time they leave the door. Okay, so EMS calls, and they're bringing us a young, call them like a 20-year-old male who was involved in a high-speed motorcycle crash. Okay, so this patient comes into the hospital as a level 1 trauma alert because they report in the field that the patient has a head strike, that he lost consciousness, that his heart rate's 120, and his blood pressure is 90/50. So that's what EMS tells us. So we have a heart rate of 120, BP of 90/50, and again, they say his GCS is a little depressed at 14, okay? So are you guys concerned or not concerned? Well, me, I'm a little worried. He's tachycardic and hypotensive technically, right? The diastolic blood pressure here is less than 60. So by definition, he's hypotensive, tachycardic. So by definition as well, what class of shock would he be in? Or hemorrhage, excuse me. 3. Class 3 hemorrhage is the first time you see hypotension, okay? That's a common test question. So the first time you see tachycardia is in class 2, and the first time you see hypotension is in class 3. Okay, so I'm concerned. So he arrives to the trauma bay, and then we begin our primary survey, okay? And then the adjuncts to our primary survey, in the primary survey, you guys will argue with me that it starts with external hemorrhage, but A, B, C, D, and E, right? So he's not bleeding externally. His airway is intact because he's able to talk to us. He has bilateral breath sounds. C now is where I'm concerned over here. So circulation is my biggest concern in this particular patient. D, disability. His pupils are equal, round, and reactive. They're equal. And his GCS is 14. And then E, on exposure, he's got ecchymosis across the left flank here. Okay? All right. So then what are my adjuncts to my primary survey? So I'm going to get a fast exam, and I'm going to get a chest x-ray, and I'm going to get a pelvis x-ray. So on the patient journey from here, we're in the trauma bay. From here, the patient only goes 2 places. Where are those 2 places? Good. So they're either going to go to the OR if they're unstable, or they're going to go to CT. All right? So let's say this guy, now he shows up, his heart rate increases to 140, and his blood pressure decreases to 60/40, okay? So C is our main concern. We need to make sure we have large bore IVs, or in this particular case, I'd probably move forward with some central access with a Cordis catheter to start some blood, because we know this guy's probably bleeding, okay? We do our fast exam, and it's positive, okay? Where is this particular gentleman headed? Nailed it. So he's going to the OR. And what procedure are we going to do? So he's going to get what we call an XLAP, or an exploratory laparotomy. This is old school surgery. We make a midline incision from just below the sternum here, okay, down just above the pubic symphysis, okay? So that is an exploratory laparotomy. We explore the entirety of the abdomen. In this particular patient, there was blood, right? And he had a bad spleen injury, okay? So then we performed a splenectomy. From here, this particular patient, because he was super sick, is going to end up in our ICU, and then hopefully he's going to go home and do really well. What would be a post-splenectomy consideration? Vaccination. Good. And what particular vaccines do we need? The encapsulated organisms. Okay? And I want you guys to tell me what those are. Okay? So, strep, meningitis, and pneumococcal. Strep, pneumococcal, meningitis, and what's my third one? I'm drawing a blank on them. You guys tell me. Forget. But we do this prior to them leaving. The question that always comes up is whether or not to vaccinate patients that undergo IR angioembolization. I say no. The literature is a little mixed, but the reason being you still have the short gastrics and the spleen is not totally gone like in a true splenectomy. Okay? So if this same patient was hemodynamically stable, okay, he wasn't tachycardic, wasn't hypotensive, then he would go to the CT scanner. The CT scan just shows a grade 1 splenic laceration. So we admit this patient and we keep an eye on them, and then eventually they go home. But the patient journey can be completely different, and this really is the main fork in the road in trauma. So from the trauma bay, all patients are either going to go to the OR if they are unstable or to CT to determine the extent of their traumatic injuries. Nice work, guys.